Good afternoon, everyone. Pleased to welcome you to our the latest event in our series on intersecting pandemics, detention, and work in times of COVID. My name is Katrina Burgess. I'm director of the Leir Institute at the Fletcher School, and we are delighted to welcome two doctors who are going to moderate the event and then give a talk. Dr. Aakash Shah will be speaking on healing justice, incarceration, the pandemic, and public health. And we're delighted to have with us as well Dr. Nahid Bhadelia, who is a graduate of the Fletcher School and currently a senior policy fellow with the Leir Institute. She's going to be moderating the event, and we're delighted to have her with us on this webinar as well. She's an infectious disease physician who has worked with the United Nations International Strategy for Disaster Reduction and the Global Fund to fight AIDS, tuberculosis, and malaria, as well as serving as a frontline physician providing care to Ebola patients in Sierra Leone with the World Health Organization. She's currently Director of Infection Control and Medical Response at the National Emerging Infectious Diseases Laboratory at Boston University and is teaching a course at Fletcher on health security, emerging infections, and outbreak response. So without further ado, I will hand the floor to Dr. Bhadelia, who will run the rest of the event.
Thank you so much, Professor Burgess, and thank you for hosting this important event. And what I want to take the time to do is first introduce our guest speaker, Dr. Shah, and then give you a little bit about how the rest of the event will go. After Dr. Shah makes his comments, we will open the event up for discussion. And so please make sure as you go through this and you hear this important topic, if you have any questions, to add them into the Q&A section on the chat. So it is my absolute pleasure to welcome Dr. Aakash Shah to the Leir Institute and to Fletcher. Dr. Shah is a practicing addiction and emergency medicine doctor at the Hackensack Meridian Health, who works on the intersection between criminal justice and healthcare reform. And its focus in particular is around building programs predicated on the understanding that for far too many caught in the maw of our criminal justice system, the ultimate manifestation of justice is treatment, should be treatment and not punishment. He's currently the director of addiction medicine and the medical director of Project HEAL, which is a hospital-based violence intervention program at Jersey Shore University Medical Center. He serves as the medical director of the New Jersey Reentry Corporation, and where he provides guidance on initiatives that to better meet the healthcare needs of those that are the justice-involved population. In the past, he's also assisted the Biden-Sanders Unity Task Force on Healthcare, staffed Health Policy Transition Committee for the Governor of New Jersey, Phil Murphy, and served on health policy councils for 3 gubernatorial campaigns, and has advised New Jersey Senate Majority Leader and members of the United States House of Representatives. So I just want everybody to give Dr. Shah a very big welcome, and we look forward to hearing your comments. Thank you, Dr. Shah.
Well, thank you for the incredibly kind introduction. I couldn't be more excited to be here. I have been hearing and learning more about the Leir Institute, and I'm just so moved by its mission, by the faculty that bring it to life, by the students that bring it to life. And so happy to share what little wisdom I have. And then candidly, I'm someone who tends to be more inclined towards conversation. And so part of what I was hoping to do today is really talk a little bit about these intersecting pandemics, talk about the COVID-19 pandemic behind the prison and jail wall. And I really just wanted to make 3 relatively intuitive, but I think nonetheless important points. And really, the first of those points is that prisons are fundamentally designed in a way that is opposed to mitigating contagion. The other is that prisons are increasingly filled with individuals who are exceptionally vulnerable to contagion. And the third is that there are better ways of structuring prison to not just mitigate contagion, but I think to promote rehabilitation, to promote, as you already alluded to, treatment instead of punishment. And so just wanted to run through each of those points and then really open it up to conversation. Happy to take any questions from the moderator, from the audience, and go from there. So I think starting with the first of those points, I don't know how many folks have actually been inside a prison or a jail, but if you have, or if you do, I suspect one of the first things you'll notice is that space is tight, right? These prisons that many folks find themselves in today were designed an incredibly long time ago, and for far fewer people than currently find themselves inside of one. You may already be familiar with the statistics, but if not, in recent decades, the US has really leaned in, for lack of a better verb, into an era of mass incarceration, and one that I'd be remiss if I didn't point out disproportionately targets Black and Brown communities. And so we now find our prisons and our jails to be bursting at the seams. It's not unusual for jail cells that were originally designed to hold just one person to now be filled with 2 or 3 or sometimes more individuals. And part of the reason I want to emphasize that is because we are living in strange times in the midst of this pandemic, and all of us have come to appreciate some of the simple but important public health measures we need to take to prevent the spread of COVID-19. Chief among them is wearing a mask and social distancing. But how do you do that in a jail cell that might be 10 by 10 feet and housing multiple individuals? How do you do that in a building where the corridors are no more than 3 feet wide, right? Physical distancing, social distancing is quite literally not permitted and not permitted by design. And so that's the first point I wanted to make. The other point I wanted to make in terms of the design being fundamentally opposed to preventing the spread of contagion is that there is a lack of hygiene in our prisons and jails. And again, going back to the sort of things that we know we have to do to prevent the spread of COVID-19, in addition to wearing masks and physical and social distancing, is frequent hand washing. Well, that's something that simply isn't feasible in most prisons and jails. In fact, for nearly the entirety of this pandemic, in the vast majority of prisons and jails across our country, things as simple as hand sanitizers, right? Purell, is not permitted within our correctional facilities. When I've pressed local officials on why that is, the reply I often get is, well, hand sanitizers contain alcohol, and we're worried that folks might drink them for the alcohol content, right? I'll be quite honest with you. I haven't come across those situations. I work a lot with those who are incarcerated and previously incarcerated. I haven't met too many who'd want to do such a thing. I've met many, many more who would simply like to have hand sanitizer, no pun intended, on hand, so that they could keep their hands clean and prevent the spread of disease, and certainly over this past year, the spread of COVID-19. But again, you walk into a prison or jail across this country, and something that we might take for granted, something as simple as hand sanitizer, something that I use more times than I can count over the course of an hour when I'm working in the emergency room, simply by law is not permitted in the vast majority of our correctional facilities. And then the other point I wanted to highlight is that not only is the design of our prisons and jails opposed to mitigating the spread of COVID-19, but so is the culture. And this occurs on multiple levels, right? At many correctional facilities, especially those that are privately run, there is a real incentive to, if not outright deny, at least delay care until it becomes absolutely necessary. And so raising your hand to seek care is just not part of the culture there. It's something that's often quite literally punished. And so, as you could imagine, when preventing the spread of COVID-19 or any other disease relies on folks who are experiencing fevers or chills or body aches, or more subtly, a loss of taste or smell, to raise their hand and say, something is amiss, I need to go see the doctor. Well, doing so in a setting that has a well-documented history of punishing individuals for raising their hands when seeking healthcare or otherwise, is something that just doesn't happen nearly as often as it should. And I think, sort of pushing that a little further, some of the other reasons why folks are hesitant to seek care behind the wall is surprising, or at least it was to me when I started doing this work. Right, I distinctly remember working with an individual who was in excruciating pain. He was telling me about how he started to feel fevers and chills, started to feel nauseous, and was throwing up. He thought the pain was right around his belly button, but started to move towards his right hip. But he remained adamant that he didn't want to seek care. Eventually, the pain got so bad that he did, and made his way to the emergency room, where I was fortunate enough to be his physician. I did my best to take care of him, and in addition to giving him medicines for pain, one of the things I did was get a CAT scan, which at that point showed that not only did he have appendicitis, but his appendix had actually ruptured, something that probably could have been avoided had he been able to come in sooner. And in the course of speaking to him, I informed him of the results. I said, "Don't worry, we're going to take good care of you. I'm glad you came in. We know what's going on, and we know exactly what to do next. I'll reach out to the surgeon to make sure that we take exactly those steps." And he turned to me and said, "Doc, I wish I had come in sooner." And I said, "That's all right. Don't blame yourself. The important thing is you're here now, and we're going to get you better." And he said, "Doc, I'm just kicking myself for not coming in sooner. You won't believe the reason why I didn't." And so I pulled my chair in a little closer. I said, "Well, tell me about it. If you'd like, I'm certainly more than happy to listen." And he said, "Doc, you know, when you're in prison, one of the few things that make you feel like a human being still is the ability to go back to your own bed at night. And when any of us come into the emergency room, when I or any of us get hospitalized and we're not in the bed that we've known for the last several weeks to months to years, even if only for one night, then our bed is given away." And I of course sympathized with him, and that was really it to our exchange. But as I was driving home that day, I came to appreciate just how profound an insight he was sharing, and one that I candidly hadn't appreciated until that moment. Right? It turns out that when you're in a correctional facility, and particularly if you're in prison for an extended period of time, there is real joy and humanity associated with the ability to have your own space, even if it's just a small and likely uncomfortable bed, and the ability to return to it night after night. And if you go to seek care and you're out of that bed for just a few too many hours, much less a night, then your bed is reassigned and you don't get to go back to it, right? And that in and of itself is so dehumanizing that even for if not all, for this individual who I was fortunate enough to find myself across, was enough of a reason to delay seeking care. And candidly, I can't blame him. I'd probably do the same. I think it's a very natural reaction. But to my larger point, right, I think prisons are structured in a way that simply makes it extraordinarily difficult to contain any contagious disease, and particularly COVID-19. And the reasons why that is one, it's incredibly hard to physically distance yourself from others. The physical layout simply does not permit it. Two, there is a lack of hand hygiene, right? Hand sanitizers are quite literally banned from entering the facility. And three, there's a culture, at times enforced by the staff, at other times instilled within the individuals who are incarcerated, that discourages seeking care, especially in a timely manner. Pivoting a little bit, the other point that I wanted to make is that prisons are increasingly filled with individuals who are particularly vulnerable to not just catching, but dying of COVID-19. And there's a couple reasons why that is. But one, it's that those in our prisons are among the most medically and socially complex patients there are. Right? One of my favorite studies was published by the Urban Institute. It was done by two authors, Kamala Malik Kane and Cynthia Vischer of the Justice Policy Center at the Urban Institute. What they had done, and at the risk of giving away the nerd in me, something that I would love to recreate or in some small way, shape, or form participate in, what they had done was they sat down with over 1,100 individuals who had recently been released from the Ohio prison system. And they just talked to them. They got to know their story, and then they, in a very focused way, got to understand the healthcare needs and challenges that they faced. And what they found was absolutely striking, at least to me, it was absolutely striking. What they found was that the vast majority of men and women in reentry suffer from one, if not more, medical conditions. In fact, what they found was that nearly 70% of individuals in reentry suffer from a substance use disorder, and increasingly in our day and age from alcohol use disorder or opioid use disorder, and in more recent years from stimulant use disorder, things like methamphetamines, crystal meth, and the like. Nearly an equivalent number suffer from mental health, or nearly an equivalent percentage suffer from mental health disorders, most commonly anxiety, depression, post-traumatic stress disorder. And oftentimes that trauma, and I don't want to get too far afield here, but happy to discuss in the subsequent conversation or Q&A, a lot of that trauma often occurs not just before incarceration, but during, and it's very real. And if we think that doesn't viscerally and biologically affect those who endure it, then I think we're mistaken. And then on top of that, nearly 50 to 60% of individuals in reentry suffered from a physical health condition, most commonly asthma, diabetes, but also hepatitis and HIV. And so all a long way of saying that the prevalence of diseases is extraordinarily high among the justice involved. And oftentimes it's the very same diseases that predispose one to a bad outcome if he or she were to catch COVID-19, right? It's things like high blood pressure, it's things like asthma and COPD, it's things like diabetes and obesity. So those are the kind of things that I think make the prison population particularly vulnerable to catching, but also suffering a worse outcome or bad outcome from COVID-19. The other point that I wanted to make in terms of why our prison population is so vulnerable to COVID-19 is the fact that they're increasingly older, right? There is a very real graying of the prison population. Over the past 2 decades, the number of individuals in prison over the age of 55 has grown by 400%. The equivalent number for those under the age of 55 has only grown by 40%, right? All a long way of saying that there are more and more older folks behind the prison wall than there has ever been. And we can, again, I don't want to get too far afield, but we can get into why that is and the way in which various policies often associated with the drug war, but sometimes not, have contributed to that dynamic. But the reality is that there are more and more folks in their 50s, their 60s, their 70s, and their 80s behind the prison wall. And we know that more so than high blood pressure or asthma and COPD or obesity or diabetes, the biggest risk factor for dying when one contracts COVID-19 is old age. And there are more and more of those folks in our prison system than ever before. And so, all of that being said, I wanted to pivot to making a relatively simple point, and that's that there are better ways of going about this, of structuring our prison experience, of reimagining our criminal justice system that not only makes sense in terms of mitigating contagion, but also makes sense in terms of promoting rehabilitation. To go back to that earlier phrase of providing treatment instead of punishment, I'm going to focus in on just one because I think it's particularly salient here, but if it's of interest, I'm happy to elaborate on sort of the 5 or 6 others that I think we need to go into if we're serious about providing treatment instead of punishment, if we're serious about bringing public health approaches to criminal justice, if we're serious about turning, just sort of being local here, the New Jersey Department of Corrections into a New Jersey Department of Rehabilitation, and not just in name, but in principle and in practice. And the idea that I wanted to highlight here, in light of the points that I've already made, is that I work with a lot of the folks that I've just described, right? Folks who are in their 60s, 70s, 80s, folks who have spent more time in prison than they have outside of it. And these are the folks who, simply by virtue of their age and their comorbidities, the other diseases that they've been diagnosed with, are at highest risk of not just contracting, but dying of COVID-19. And they're at even greater risk because the fundamental design of the facility, the prison in which they're in, is opposed to taking the very basic measures needed to prevent spreading COVID-19. And one of the things that that comes to mind for me is, why don't we simply institute a system of rehabilitative release? And what I mean by that is, like, these are individuals who need to move into a different setting in order to prevent the spread of COVID-19. And so, given the times that we're in, why not take over, quite candidly, a distressed hotel that's about to go under, and create a therapeutic community, a rehabilitative community where these individuals are still under supervision, but are part of a setting in which they have the rituals, the rhythms, the routines needed to structure a more meaningful day and to work through the trauma that they've endured, right? If you move someone into a therapeutic community like that, again, say in a distressed hotel where you can do the physical distancing needed, where you can have the hand hygiene needed to prevent the spread of COVID-19, where you can have, to use the phrase I used earlier, the rituals, the rhythms, the routines needed to work through the trauma you've endured and structure a more meaningful day, then you at once prevent the spread of disease and help individuals heal and rehabilitate. And I think this makes sense not just during the pandemic, but beyond, because I can tell you, in having worked with a number of these individuals and having listened to their stories and gotten to know them, I've realized that the vast majority of them are no longer the same person that they were when they were convicted of a heinous crime those many decades ago, right? In much the same way that no one at 30 or 40, much less at 50 or 60 or 70 or 80, is the same person they were when they were 16 or 19 or 23. These individuals certainly aren't the same person they were when they were convicted of a heinous crime so many decades ago. And the statistics bear this out, right? This is the population that is least likely to reoffend and recidivate. In fact, studies have shown that among those in their 60s and 70s and 80s, the risk of reoffense is less than 1%, which means that you can safely move these individuals into a therapeutic community and allow them to heal without posing any risk or having to worry about any significant amount of reoffense and recidivism. And I would argue that this makes not just, as a physician, it not only makes clinical sense to me, but I think as sort of a policy nerd, it makes policy and economic sense to me, right? If you have folks in their 60s, 70s, and 80s under the custody of, say, the New Jersey Department of Corrections, well, this is the age where health issues are likely to arise and healthcare expenses are likely to rise. And if they're under the custody of the New Jersey Department of Corrections, then it is the state government that is going to have to foot that bill. Yet, if you move them into a therapeutic community, you at least partially shift the expense of their healthcare onto Medicaid, onto Medicare. Not only that, but a distressed hotel is probably going to cost less than the accommodation in a correctional facility, right? Again, just being local, the cost of incarceration in my state, in New Jersey, is $60,000 per person per year. I assure you that at a cost of $60,000 per person per year, you can absolutely take over a distressed hotel and put in the kind of clinical and therapeutic staffing that I'm describing, and have better health outcomes and a more meaningful existence for those who are part of that community, without posing any additional risk to the population at large. Anyway, my wife would be the first to tell me that I talk too much. So let me wrap up there. Again, the 3 points I wanted to make were the design of our prisons is opposed to preventing the spread of COVID-19, that our prisons are increasingly filled with individuals who are at very high risk of contracting and dying of COVID-19, and that most importantly, that there are better ways of structuring these systems to not only protect the safety of those inside them, but those outside of them. And I think in a way that's much more consistent with the overall goal of our criminal justice system, or at least what it ought to be, which is to rehabilitate individuals and promote the safety of all individuals, those inside as well as those outside. That being said, more than happy to take any questions and go from there.
Dr. Shah, thank you so much for that. Just incredible, insight into what's been a complicated, the way this pandemic's played out in the United States. All the groups that could not, if the primary risk factor is sharing air with others, the groups that don't have the luxury to be separated from others. We've talked about our prison populations, but the same thing applies to our factory workers, to our patients with housing instability that end up being in shelters that may be overcrowded. But this idea that these are vulnerable systems to begin with, but your points are so salient in terms of the fact that it's not just the physical structure, but even the culture, in many of these settings. And just to put a number on this, I saw a report, and you'll have to tell me if this is right, in December of 2020 that said 1 in 5 prisoners in the US has had COVID. I think it's just an incredible, how incredibly we failed at protecting those who are incarcerated currently. I did want to reflect on one thing that you mentioned, because you started talking about it towards the end of it, which is the mitigation. Given that we can't change the system overnight, right now with what we have, you mentioned the idea of recuperative, rehabilitative release, and the idea of having maybe people lead to a safer space where those infection control measures could be had. Can you comment on what right now, finding ourselves in this mess, what are some of the mitigation strategies we can use now until COVID becomes a bit more distant memory, of reducing this kind of vulnerability among our prison population?
Yeah, no, I think that's spot on, because I think you're right that while I am a huge proponent of rehabilitative release, of rehabilitative housing, and I think we're going to start down that path in New Jersey, even here where we've got a number of folks eager to lean into it, we probably aren't going to be able to get it off the ground for a number of months. And the reality is that with each passing month, much less week, much less day, there are additional individuals who are contracting COVID and dying of COVID, and that is a tragedy unto itself. So in terms of immediate measures that need to be taken, I think the dynamics that are playing out parallel that of the general population, which is we are in a race between vaccines and increasingly these variants, which here in New Jersey seem to be taking off. And I don't think we've gotten all the data we need to fully appreciate that, but I can tell you, just having worked in the emergency room last night and a number of nights over the past couple of weeks, that the caseloads are rising and rising at an impressive clip. So I think we've got to vaccinate those behind the wall, as well as the correctional officers who serve behind the wall. And my argument here is simply that I think one of the sort of from a clinical perspective, one of the most logical or fairest ways, or at least in my mind, to prioritize vaccinations is simply by level of risk. So if we know that those who work in prisons or those who are incarcerated in prisons are at higher risk than the general population, but at lower risk than healthcare workers and nursing home residents, then it makes sense to me that we should vaccinate them sometime between healthcare workers in the nursing home population and the general population, and making sure that our prioritization reflects level of risk, I think is just, again, from a clinical, or at least my personal clinical perspective, the most logical and effective way to go about mitigating the fallout from this pandemic.
I'm going to take one more prerogative of the moderator before I pass it on to others for questions. I'm fascinated with this idea of how do you take a public health approach to prisons, and you mentioned some of the strategies, but you said that you could expand on that. What would you like to see? I mean, the timing seems right. Right now we've got the pandemic, which is really the upheaval, not just to the prison system, but the healthcare system in general, and to our political system. And then you have this year, the year of calling for racial justice, the year for really valuing Black lives and looking at how our sort of system of incarceration has unduly burdened people of color. Moving out of this, what would you like to see? What do you see opportunity there, and what do you hope happens from that public health perspective in terms of our incarcerated populations?
And this is something that I've found myself having a number of conversations with folks about, right? I think, to your point, I often find myself chatting with folks, and they look back at the kind of things that have dominated our headlines over this past year, right? And they're really headlines about the COVID pandemic, as well as the deaths of those like Breonna Taylor, Daniel Prude, George Floyd. And I think a lot of individuals sense that these two are connected, but sometimes they find themselves reaching to articulate how. And I would argue that we don't have to reach too far, right? It comes down to this idea, and this is by no means an original idea, but it comes down to this idea that budgets are moral documents, right? Hence this phrase that you don't need to tell me your values, just show me your budget and I'll tell you your values and the precise extent to which you value them. And so if we take that to be true, then I think the question it forces us to ask is, well, what would our conversation today look like? What would our headlines over this past year have looked like if we had invested in our public health departments the way we invest in our police departments, if we had invested in testing and tracing and isolating the way in which, not in this state, but in many others, we invest in warrior style trainings and military equipment for our law enforcement officers. And I think the answer would be is that we'd be having a very different conversation, and we'd be reading very different headlines, right? We'd have far fewer cases of COVID-19 and far more good folks like Breonna Taylor, Daniel Prude, and George Floyd. And so I think in part what that's prompted me to do, and part of what I'm now committing myself to is, well, if we are to reimagine our criminal justice system to that lens, to pull on that example from earlier, if we are to transform the New Jersey Department of Corrections into a New Jersey Department of Rehabilitation, and not just in name, but in principle and practice, what would that look like? And I think from a public health perspective, it probably starts with 5 or 6 different programs. And I won't dive into each and every single one of them. Again, I as you've already discovered, I talk too much, but I happy to share sort of how I think about it, right? Because when I think about one's journey through the criminal justice system as it currently exists, I think it has 3 points along it. And the first point is prevention. So there are things that we're doing here in Jersey, and I applaud our state leaders for doing it. I applaud my healthcare system for taking the lead on it. around thinking about violence as a public health issue. And so one of the programs that I lead here at Hackensack Meridian is a hospital-based violence intervention program. Boston certainly has its own hospital-based violence intervention programs, and they're phenomenal, right? But the whole idea is if we were to involve clinicians and take a public health approach to cycles of violence in our community, what would it look like? And if you read a bit more about hospital-based violence intervention programs, you'll realize that they're just one of several evidence-based practices to doing exactly that. I think moving further along the spectrum from prevention to first response, and I almost hesitate to use that phrase because I realize that depending on your community, there's no such thing as a quote unquote first encounter with the criminal justice system, right? Its presence is often omnipresent and seemingly constant. But to the extent that there is a first response, you know, I think of the case of someone whose name I mentioned earlier, Daniel Prude, someone who, you know, in his 40s or 50s, not all too far from here in Rochester, New York, had a history of schizophrenia. And you might be familiar with the case, but if not, he suffered a psychotic break, ran out of his brother's apartment with very few clothes on into the cold rain. His brother, not knowing what to do, did what many of us would, myself included. He called 911, and the police were able to find his brother hours later in the cold rain. Unfortunately, in an attempt to restrain him, ultimately Daniel experienced a cardiac arrest, right? His heart stopped beating. To the credit of law enforcement, they initiated CPR and they had a return of his pulse. His heart started beating again, but only long enough for Daniel to be taken to the local hospital where he was pronounced dead just days, if not hours later. And the question that brings to my mind is, you know, again, as a clinician and through a public health lens, does it really make sense for us to dispatch a man or a woman with a firearm at his or her hip to the scene of someone having a florid psychotic break? And above and beyond the answer to that question, what type of training do we give him or her to deal with a situation like that? And above and beyond that, once they've dealt with the situation, what type of resources are they able to connect that individual in distress to? Are they able to connect them to the mental health services that they need and deserve, or are they forced to reflexively incarcerate that individual? And so, again, I think a mental health first response, and this isn't a novel idea, right? There are pockets of this country that have been doing this day in and day out for well over a decade. Eugene, Oregon, and its Whitebird Clinic has demonstrated the efficacy of this. They fielded over 20,000 calls, I believe. You know, someone calls 911, the dispatcher triages to either a traditional law enforcement response or a mental health first response from the Whitebird Clinic. The latter has fielded over 20,000 calls, I believe. In fewer than 200 have they needed backup from traditional law enforcement. In none has anyone, be it the first responder or the individual in distress, been harmed. And so to me, it seems like a more thoughtful, evidence-based public health approach to dealing with some of these crises. And then sort of moving from prevention to first response to incarceration, again, I think a lot of it is alternatives to incarceration. So for older folks in our prison system who have been inside for longer than they have been out and who pose little harm of reoffense, is there a therapeutic community we can move them into to help them rehabilitate? The same goes for those who have been incarcerated on nonviolent drug arrest, right? And there's a number of other alternatives to incarceration, but in broad strokes, I think that's how I'm thinking about the relationship between public health and the pandemic and the challenges around racial injustice that we're facing. And from there, sort of the very real, tangible programming that we could implement to reflect an appreciation of that connection.
That's really great. Thank you so much for that. I'm going to actually turn it over to Professor Burgess, who I believe has a question before I go to some of the audience questions. There's been a lot of activity in the chat. Happy to share in a second. Professor Burgess.
Yes, thank you so much. And thank you, Dr. Shah. This has been a fascinating conversation. And I actually have a number of questions, but let me choose one and that follows from the conversation that you and Dr. Bhadelia have been having. And that's about the punitive political culture that I think we have in this country. And it's been referenced a couple of times. And I think it's related to a kind of deservingness narrative. And I work on immigration, and you see this all the time, including with regard to immigrant detention, where we find a number of similar issues. And so I'm just wondering whether you've mentioned some programs that push back against that narrative and some evidence that it's rational. It's in all of our best interest to find alternatives to incarceration. But I'm wondering if you have any other thoughts on how to push back against or challenge this sort of deeply seated punitive reaction that many people in this country have, that I think has contributed to the entrenched nature of these problematic arrangements. Thanks.
Yeah. No, so I think there's a number of different ways. My mind often gravitates, again, because I'm a policy nerd, to sort of the policy responses, but I think I'd like to use this opportunity to highlight a different one that I have been struck by and have a growing appreciation for, which is the role of connecting those at formative stages, and what I'm getting at here is students, to opportunities and communities of those who've been incarcerated or previously incarcerated, right? So I'm fortunate enough to be building out an institute that looks at public health approaches to criminal justice. I've been even more fortunate to connect with a number of students who are helping me think through what those public health approaches to criminal justice will be and how to best communicate them. I kid you not, over half of those I've connected with have independently gone through and cited their experience with the PD Green program when they were college students as why they have come to appreciate the humanity of those behind the prison wall, to have a desire to empathize with them instead of penalize them, or to lift your verb, to punish them. And so to me, it strikes me as an incredibly enduring impact for those who might be familiar. And I admittedly wasn't until all these students I work with started saying, oh yeah, gosh, I'm interested in this because, you know, I had this experience with PD Green when I was here or I was there. It is a program that introduces mostly undergraduate students, or connects undergraduate students with opportunities to tutor inside prisons and jails. And students often do so for a semester or a year. Those who are deeply moved by it might spend a year or two as paid staff with the program upon graduation. But again, just so many individuals who have not just no longer feel an impulse to punish, but actually reflexively have an impulse to empathize with those who find themselves between a rock and a hard place behind the prison wall. And so I think programs like that have tremendous impact. And this is a bit tangential, but again, revealing how much of a nerd I am. You know, one of the things that struck me when you pick up a book from a seemingly different field, like Thomas Kuhn's The Structure of Scientific Revolutions, right? They're very clear that when you want to bring about a paradigm shift, you don't change the minds of your peers, right? You change the minds of their children. And the PD Green program strikes me as a quintessential example of doing exactly that, right? I spend a lot of my days trying to convince folks who are older than me or my age, but it's not lost on me that if I'm serious about making the change that that I'd like to see in this world, the minds that I need to be changing are those that will soon follow, and in many ways already have. And so, yeah, I just applaud the Leir Institute, the Fletcher School of Tufts, because that is part and parcel of what all of you do day in and day out.
And Dr. Shah, I actually want to point to this powerful thread in the conversation that you and Dr. Burgess just had, but I think what your remarks said, which was what seem at first like technical issues, the way the prisons are designed or availability of hand sanitizers, when you tease them apart, fall into the cultural issues of how we look at punishment and judge people, once they've made a mistake, or the economic ones, how we decide how budgets are made, and the political ones, or the policies that go behind that, to support those cultural beliefs. So I think those are definitely in the realm of the policy nerds here at Fletcher. But so I think they appreciate that very much. I'm going to take some of the questions that we have from the audience. If you have any other questions, guys, please keep putting into the Q&A. So here's a question from Daniel Cooper. He says, I wonder if Dr. Shah can comment on what I've seen as a bureaucratic morass in many prison health systems where inmates cannot receive regular health screening or even needed medical equipment in a timely manner, and how that affects health in prison. And he followed up with an addition saying to the above question, what are Dr. Shah's thoughts on getting rid of qualified immunity?
Yeah, so I'll take it in two parts, but I think you're absolutely right that healthcare in the correctional system is a far cry from where it ought to be. I think a lot of that ultimately reflects the stigma and, by extension, the culture that often pervades our correctional system. And candidly, I can't fault any individual or any group of individuals for it, right? One of the other hats that I wear is around addiction medicine. And so I'm often working with those who suffer from substance use disorders. There are some great medications to help those who suffer from substance use disorders, opioid use disorder in particular. It has been an uphill battle to get my colleagues who are in healthcare to make the most of these medications. And I would argue in part because of the stigma and culture that has pervaded medicine itself for a number of years, if not decades, if not longer. And so if it's difficult for me to push back against that among healthcare providers, it is all the more so to push back against it among correctional staff, right? There is a qualitative difference in the level of challenge and, by extension, persistence and persuasion needed to get my medical colleagues to do right by this population when, for instance, they're in the emergency room, right? Healthcare providers, I think the world, I'm biased, I am one of them, but we, myself included, often fall far short of giving the justice-involved population the care that they need, even when they're right before us in our own emergency rooms and in our own hospitals. I could only imagine how much more real that stigma is, how much harder it is to push back against that culture when you're not even in a medical facility, but in a correctional one. And so it's an incredible challenge. And I wish I knew ways around it other than simply waking up each day, thinking about these issues, falling asleep each day, thinking about these issues, and in between trying to do the candidly often mundane work of jumping on the phone, sending out emails, writing memos, trying to structure policies in a way that helps close that gap and fight that stigma and change that culture. Pivoting to the other part of your question around qualified immunity, I think it is an area. Yep.
Sorry, Doctor, could you share what, for the general audience, could you share what that is?
Yeah. Absolutely, and I should start by flagging that as much as I work on criminal justice issues, I am by no means in the weeds on all of them, and so I'm passionate about them. I'm always learning more about them, and qualified immunity is one of those that I still have a lot more to learn about. So, all of those caveats said, my understanding is, and feel free to correct me if I'm wrong, type into a chat, feel free to interrupt me, I certainly won't be offended. But my understanding is that qualified immunity is one of the mechanisms through which prosecuting law enforcement officers who have been accused of brutality or violence against an individual are significantly more difficult to prosecute. In my mind, conceptually, it seems like if it's going to come down to a he said this and she said that, qualified immunity structurally ensures that our current criminal justice system gives the law enforcement officer the benefit of the doubt and protects them from being prosecuted of the allegation. Again, that's just how I understand it, but I do not spend nearly as much time reading or writing about it as I do about medications and prescriptions and the like. So take all of it with a grain of salt. That being said, if what I'm describing is indeed what it is, then it strikes me as the kind of thing that needs to change, simply because I cannot think of a compelling reason, at least as I think out loud here, I cannot think of a compelling reason why any individual, whether they're a law enforcement officer, a healthcare provider, or otherwise, should be immune from being held accountable for any crimes that he or she may have committed. And I say that, again, not just of law enforcement officers, but also healthcare providers, myself and anyone else. To me, just on a fundamental level, it seems like everyone should be equals and should not be immune from being held accountable just by virtue of what they do or any other reason that I can think of.
Right. Daniel makes the point that it's not just for law enforcement, but also for government officials in general as well. So it's more applied to civil liability violations. I'm gonna, just for the sake of time, I'm gonna go to questions, two questions from Neha, and they're kind of tied. I think you answer the first one. She says, and this is for the public health approach to the prisons. She says, this seems like a harm reduction paradigm. I think it was applied to the rehabilitation program that you were talking about, the release, which I'm completely personally in favor of, but as with other situations where paradigm is applied, such as keeping liquor stores open as essential businesses, decriminalizing sex work, public buy-in seems to be an issue. How do we ameliorate general public opinion that at best renders incarcerated persons invisible and at worst casts incarcerated persons as irredeemable and therefore somehow unworthy of treatment and care? And I think this went to Professor Burgess's question about how do we change minds around this. And I'm just going to add Neha's last question here so you can respond to the two, and then we'll end with that. How does he bridge the distrust that historically marginalized groups in the US feel towards medical system, given that so many incarcerated persons belong to the very communities that have long been either instrumentalized by or ignored by the medical system? Oof, yeah, two very important questions we may not be able to solve in the last few minutes, but I'd love to get your reaction to those.
Yeah, no, happy to react, happy to think out loud about them. So to the first, I really do think that that we've got to bring about a paradigm shift on this scale. I think it really does require exposing individuals to those who otherwise they simply have to imagine and by extent project their biases onto. So I really do think that structuring educational opportunities, creating communities that bring individuals in conversation with those who they otherwise would have difficulty empathizing with is absolutely the way to go. And I think there are, I'm just thinking out loud here, but there's probably a number of ways to expand this, right? I mean, there's now talk about a national community service program or additional opportunities around that with the stimulus. Well, I think there's a number of ways in which that could be structured to help unify the country at large, but even in a more modest sense, I think it could be used to bring individuals in community with the justice involved, and in doing so, I think we'll start to have a much more thoughtful conversation around what these public health approaches to criminal justice need to look like. This is a bit of a tangent, but you had alluded to harm reduction. We've talked a little bit about addiction medicine. I would argue that's part of what we've seen in this country's struggles with the opioid epidemic. And again, we touched on race earlier. I'd be remiss if I didn't touch on the way in which race, as it seems to with so many things in this country, intersects criminal justice, drug, and healthcare policy, right? The opioid epidemic is not the first drug epidemic that this country has faced. In fact, we need to look no further back than the 80s to see the last one, and that was, of course, the crack cocaine epidemic. At that time, our collective response to it was to treat drug use as a moral failing, to treat it as a crime, and to reflexively punish it. You fast forward a couple of decades, and we now find ourselves in the midst of the current drug epidemic with opioids. And this time around, our collective response has been very different, right? We understand it to be a disease, and a disease for which we need to use medications and provide treatment instead of punish and incarcerate further. There is no denying, in my mind at least, that our more understanding and I think accurate response to this epidemic is directly tied to the color of the communities who are affected, right? In the 80s, the crack cocaine epidemic disproportionately affected people of color. And so our response looked very different than it does today to the opioid epidemic, which, at least when it started, disproportionately affected white communities. And so, again, I think finding, and I think the implicit point there is that our policymakers have been disproportionately white, and by extension, disproportionately knew individuals who had been affected, right? I come from a state in New Jersey where our previous governor made national headlines for his leadership on the opioid crisis. He personally knew someone who had been affected by opioid use disorder, and that completely changed the state's response to the crisis. And so, again, finding ways to be in community by those who are most affected by the issues we're wrestling with, whether it's immigration, whether it's drug use, whether it's sex work, whether it is incarceration, finding ways to be in community, I think, is how we, over time, change this. To the second question, and forgive me, Dr. Bhadelia, can you refresh my memory on the second part?
Sure, I think it was related to bridging the historical distrust that exists among marginalized groups. Yeah, the medical system, and I know we're sort of edging up towards the end of the hour as well, but I think it'd be, I know that's such an important part of this topic.
Yeah, I think the way I have approached it, at least in day-to-day practice, and it is by no means a perfect solution to it, but I think I simply try to practice to the best of my abilities while also being cognizant of the many biases that may have crept into them, and try to be proactive in combating them. And so what I mean by that, and again, this is a bit tangential, but when I find myself across from an individual in need, I do my best to do the little things that I think signal that I'm just there to help. So from my body language to my tone to actually pulling up a chair, right? So again, this is going to sound very almost trivial or minor, but I work in the emergency room. Interactions with patients are often just minutes long. Few providers, and I'm guilty of this myself, ever take the time to pull up a chair. One of the few times I'm deliberate in doing so is when I think that there is going to be a distrust, and often rightly so, of the provider, in this case me, right? So last night I'm treating someone who had gone through a lot as a result of his injection drug use. It was probably the only instance last night that I actually went around the corner, found a chair, brought it over, and placed it by his stretcher in the hallway before starting the conversation. And again, it's one of those things that I find just helps signal that that the only person I care about in the here and now is the person across from me. I can't pretend that it works every time, and I can't pretend that it should, because the distrust that we're trying to work through is real and often very justified. But at least in my day-to-day practice, those are the small ways in which I try to do my bit towards truth and reconciliation, even if not explicitly.
And for those who are listening, you may not realize, but Dr. Shah was working overnight in the emergency room last night, right before joining us this morning. And so we're incredibly thankful for you joining us and talking to us about this important topic, and about the dynamics underlying all of this stuff. I also want to thank the Leir Institute for hosting the event, as well as the participants for your insightful questions. So thank you so much. I'll turn it back to Professor Burgess.
Thank you so much. I want to echo Dr. Bhadelia's thank you and appreciation. This is a wonderful conversation. Thank you, Dr. Shah. And particularly, you really bring the kind of spirit that we want to promote at Leir of humanization and empathy. And if I ever find myself in an emergency room, I would be so happy to have you at my side, or a doctor with a similar approach. So thank you for all the great work that you do, both on a daily basis, but also on using your policy nerd side. It's really wonderful. And we really appreciate you taking the time after a long night to share some of your thoughts with us.
No, thank you.
Thanks, everybody. Have a good day. Stay well.